In this presentation, we will review the image analysis of wrist projections, specifically the PA, the external oblique, the lateral, and the PA axial scaphoid projection. We will review image analysis guidelines, common positioning errors, and ways to take corrective action. Let's start with the PA projection of the wrist. I've provided for you an image of proper positioning for PA wrist projection and a image, but we're going to move forward to the labeled image just to help you visualize while we are reviewing the image analysis guidelines. Guidelines state that the ulnar styloid should be in profile medially. The radial styloid should be in profile laterally. The radio-ulnar articulation should be demonstrated as open. Superposition of the metacarpal bases is limited. The radioscaphoid and radiolunate joints should be demonstrated as closed. The anterior and posterior margins of the distal radius are not superimposed. Posterior radial margin superimposes no more than 1/4 of the lunate. The 2nd through 5th carpo-metacarpal joint spaces are open. The long axis of the 3rd metacarpal and mid-forearm should be aligned. The lunate midpoint is positioned distal to the radio-ulnar articulation. The 1st metacarpal is seen without 2nd metacarpal superimposition. The carpal bones are at the center of the exposure field. The carpal bones, 1/4 of the distal ulna and radius and half of the proximal metacarpals are included within the exposure field. I will say with the one caveat is dependent upon hospital protocol will depend upon how much of the distal radius and ulna and metacarpals you will capture within your projection. Here are those image analysis guidelines for your review. So let's look at some common positioning errors when conducting a PA projection of the wrist. The first I wanted to take a look at is the effects of external wrist rotation. When the wrist is externally rotated, there are some key changes that can be observed. The medially located carpal bones and metacarpal bases show an increase in superimposition, which results in a decrease of the visualization of the carpal joint spaces. The laterally located carpal bones and metacarpal bases demonstrate less superimposition, leading to an improved view of those carpal joint spaces. In addition, the radio-ulnar articulation will be demonstrated as closed due to this rotation. These changes in positioning can affect the alignment of the wrist anatomy. So it's important that we ensure proper rotation to avoid overlapping of structures and achieve that optimal joint space visualization. Conversely, when the wrist is internally rotated, the laterally located carpal bones and metacarpal bases will show increased superimposition, which reduces the visualization of the carpal joint spaces. The pisiform and hamate hook become more visible, making these structures easier to identify. The radio-ulnar articulation is closed again due to that internal rotation. And in this case, proper positioning is crucial to avoid unnecessary superpositions of structures that we are trying to visualize in the PA projection. Another common positioning error I wanted to discuss is some wrist flexion when the wrist is flexed in a radial deviation or ulnar deviation. To ensure that the wrist is in a neutral position, the long axis of the third metacarpal and the mid-forearm should be aligned. This position places the midpoint of the lunate distal to the radial-ulnar articulation without any radial or ulnar deviation. When that wrist is deviated, you can see how this alters the shape of the scaphoid and changes the position of the lunate in relationship to that radio-ulnar articulation. This imaging here demonstrates how proper wrist alignment is essential for accurate imaging and proper visualization of the carpal bones. Go ahead and review this practice analysis of the PA wrist projection and answer the following question. So let's review this PA wrist projection together. First, you want to determine if you have all your anatomic structures. And in this case, we have the distal half of the distal metacarpals and all the way to the distal radius and ulna included within the imaging, and all our carpal bones are within the imaging as well. Next, we want to determine if the anatomy is adequately positioned. When in this case, the third metacarpal is misaligned with the long axis of the mid-forearm. This indicates that the wrist is in radial deviation. Additionally, the second and third carpo-metacarpal joints are closed, and the metacarpals are aligned more than 10 to 15 degrees with the image receptor. To correct this, we need to deviate the wrist until the third metacarpal is aligned with the forearm's axis, and decrease the angle between the metacarpals and the image receptor, ensuring a more adequate or accurate PA wrist projection. Take your time and review this PA wrist practice analysis and answer the following question. So let's review this PA wrist analysis together. Again, you want to make sure that you have all your anatomic structures, with which we do. Next, you want to evaluate, are we adequately positioned? And in this image, the medial carpals and the proximal metacarpals are superimposed, and the radial ulnar articulation is closed. The wrist is actually positioned in an external rotation. It looks more like an oblique projection. Also, notice that the posterior radial margin superimposes more than 1/4 of the lunate, and the forearm is not parallel to the image receptor. To correct this, we need to internally rotate the wrist to achieve that PA projection that we need. Additionally, we need to address the proximal forearm to ensure it is aligned parallel with the image receptor. This will provide a much more accurate representation of the wrist anatomy in the PA projection. Let's move on to the PA oblique projection. external rotation. Image analysis guidelines for the PA oblique projection and external rotation state the ulnar styloid should be demonstrated in profile medially. The long axis of the third metacarpal and mid forearm are aligned. The lunate midpoint is positioned distal to the radio-ulnar articulation. The radioscaphoid and radiolunate joints are closed. The anterior and posterior margins of the distal radius are not superimposed. The posterior radial margin superimposes no more than 1/4 of the lunate. The second carpometacarpal and the scaphotrapezial joint spaces are demonstrated as open spaces. The trapezoid and trapezium are demonstrated without superimposition. The trapezio-trapezoidal joint space is open and the trapezio-capitate joint space is closed. The fourth and fifth metacarpal midshafts demonstrate a small separation between them. The carpal bones are at the center of the exposure field. The carpal bones, 1/4 of the distal ulna and radius, and half of the proximal metacarpals are included, all within the exposure field. Here are those image analysis guidelines for your review. So let's discuss some common positioning errors that occur during a PA oblique projection with external rotation. First, I want to focus on radial deviation. Typically, patients will deviate their wrist just because they are flexing while they're holding their wrist in this position. When there is radial deviation, it can be identified by the third metacarpal will points towards the medial side of the wrist. This shifts the lunate medially, positioning more than half of the lunate distal to the ulna, as you can see here. In contrast, in ulnar deviation, this causes the third metacarpal to point towards the lateral side of the wrist, and it moves the lunate laterally, so less than half of the lunate is distal to the ulna. You're not going to see a lot of people recognize this or even repeat for this imaging error. However, I want you to be cognizant of the positioning of the wrist, and if the patient is ulnar or radial deviating, we need to make sure that they are in a neutral position to adequately align the third metacarpal with the midpoint of the forearm. So let's talk about positioning errors when it comes to obliquity. We're going to start with insufficient obliquity when the wrist is obliqued less than that 45 degrees. If you recall, an adequately positioned PA oblique projection will represent the trapezoid and the trapezium demonstrated without superimposition. Also, the trapezio-trapezoidal joint space should be open, and the trapezio-capitate joint space should be demonstrated as closed. In insufficient obliquity, the trapezoid can be identified because it has a cone-like shape with a wider posterior end and a pointed anterior end. When the wrist is more in a PA projection, which is representative of figure A here, the trapezio-capitate joint will be parallel to the central ray and appear as an open space. However, the trapezio-trapezoidal joint space is closed because the trapezoid overlaps about half of the trapezium. To correctly open that trapezio-trapezoidal joint space, the wrist must be obliqued in that 45 degree. This degree of obliquity rotates that trapezoid off the trapezium and aligning that joint space parallel to the central ray while simultaneously closing the trapezio-capitate joint as the trapezoid overlaps part of the capitate. Now, if you look at figure that is labeled B, this is representative of a wrist that is obliqued, but it's obliqued less than 45 degrees. In this case, the trapezio-capitate joint may remain open and the trapezio-trapezoidal joint space will remain closed, with the posterior trapezoid overlapping the trapezium. Additionally, you may still see some midshaft overlapping of the third through fourth or fifth metacarpals, which should be demonstrated, but yet we are not actually demonstrating those structures that are required for the PA oblique, such as the trapezoid and the trapezium demonstrated without superimpositioning, thus opening that joint space. Now let's take a look at excessive wrist obliquity. When the wrist is obliqued more than that 45 degrees, both the trapezio-trapezoidal and trapezio-capitate joint spaces will be demonstrated as closed. The trapezium begins to overlap that anterior aspect of the trapezoid, and the trapezoid increasingly overlaps the capitate. There also will be an increase of superimposition of the metacarpal midshafts as well. In this case, you're going to decrease the obliquity to that 45 degrees to optimally visualize the anatomic structures that are required for this projection. Please review this practice analysis and complete the next question. So let's review this practice analysis together. First, we want to take a look and determine whether we have all our anatomic structures. In this case, we have from the mid shafts of the metacarpals to the distal radius and ulna, which is what is required. So we check that box. Next, we wanted to determine, are we adequately visualizing the anatomic structures for this projection? So let's take a look at what we see. Here in this projection, the trapezio-trapezoidal and trapezio-capitate joint spaces are both closed. That is a sign that the wrist is over-rotated medially beyond the ideal 45 degrees. You also can see here that the trapezium is overlapping part of the trapezoid, and about half of the trapezoid is superimposing the capitate. Looking at the metacarpals, the midshafts of the fourth and fifth metacarpals are superimposed, which shouldn't happen if the obliquity is correct. Additionally, the posterior radial margin is overlapping more than 1/4 of the lunate, indicating that the proximal forearm wasn't aligned parallel with the image receptor. Lastly, if you take a look at the ulnar styloid, it is not in profile. So how do we fix this imaging? First, we need to decrease the medial wrist obliquity to 45 degrees. This will open up our joint spaces and improve alignment of the trapezium, trapezoid, and the capitate. Then we should make sure that the proximal forearm is depressed so it's parallel with the image receptor. This will eliminate the radial margin overlap and improve overall alignment of the wrist. Lastly, you can check to make sure that your humeral epicondyles are perpendicular with the IR. This will ensure proper alignment of the distal wrist to the IR without any flexion or misalignment of the anatomy. Go ahead and review this practice analysis and answer the following question. So let's take a look at this practice analysis together and figure out what's going on here. In this practice analysis, like we always start out, just make sure that you have all the anatomic structures that are required to be within the field of view. Next, we want to look at the positioning to determine whether or not we are demonstrating the anatomy for this projection. So, when analyzing this projection, we can see that the second metacarpal is overlapping the trapezoid. This tells us that the hand is flexed more than it should be. So we definitely want to decrease that flexion so that it is aligned with the anterior wrist plane. Next, we notice that the posterior radial margin is superimposing more than 1/4 of the lunate. This happens when the proximal forearm isn't aligned parallel with the image receptor. It's actually elevated higher. We also can see that the trapezio-trapezoid joint is closed and the wrist is rotated externally beyond that ideal 45 degrees. So how do we correct these issues? We want to start by reducing that hand flexion. We want to depress that proximal forearm so it's parallel with the image receptor. And then finally, we want to decrease that external rotation to that 45 degrees so that we can obtain that optimal image for the PA oblique projection. So let's move on to the lateral wrist projection. Image analysis guidelines for the lateral wrist projection state that the ulnar styloid should be demonstrated in profile posteriorly. The anterior aspects of the distal scaphoid and pisiform are aligned. The distal radius and ulna are superimposed. The second through fifth metacarpals are aligned and placed at a 10 to 15 degree angle with the anterior plane of the wrist. The trapezium is demonstrated without superimposition of the first proximal metacarpal. The first metacarpal is demonstrated without foreshortening. The carpal bones are at the center of the exposure field. The carpal bones, 1/4 of the distal ulna and radius, and half of the proximal metacarpals are included within the exposure field. Here are those guidelines for your review. So let's talk about evaluating the alignment of the distal scaphoid and pisiform on a lateral wrist projection. This alignment is a reliable way to check if your imaging was captured without rotation or deviation. In an ideal alignment, in proper lateral rotation projection, the anterior and proximal cortical margins of the distal scaphoid and pisiform should align perfectly. This is what you want to aim for in a true lateral projection. So what happens when there's rotation? In external wrist rotation, as demonstrated in this image, The anterior aspect of the distal scaphoid will sit posterior to the anterior aspect of the pisiform. This is indicative of external rotation. On the other hand, if the anterior aspect of the distal scaphoid is positioned anterior to the pisiform, then the wrist is in internal rotation. By paying attention to these relationships of the pisiform and scaphoid, you can quickly identify those rotational errors and make the necessary changes to achieve that true lateral projection. If you recall the image analysis guidelines, they state that the second through the fifth metacarpals are to be placed at a 10 to 15 degree angle with the anterior plane of the wrist. And this imaging here is just to show you how flexion and extension can obscure anatomy. When there's any flexion and extension, then the trapezium will be demonstrated with superimposition, and it changes the position of the pisiform and distal scaphoid's relationship. So it is important to make sure you're within that 10 to 15 degree angle with the anterior plane of the wrist to show the anatomy appropriately. One last common imaging error I wanted to discuss is when the thumb is not depressed adequately, it will foreshorten and superimpose over the trapezium. And if you recall, image analysis guidelines state that we want to see that trapezium without superimposition. Go ahead and review this lateral practice analysis and complete the next question. So let's go ahead and review or evaluate this image together. First, you want to determine whether we have all our anatomic structures, and we do. There might be a little bit of central ray misalignment, but we're really looking today here at positioning. Now let's analyze whether or not we are demonstrating the anatomy of interest for this lateral projection. Looking at this projection, you can first see that the distal scaphoid is positioned anterior to the anterior portion of the pisiform. We don't even see the pisiform at all, hardly. Also, you can see that the radius and ulna, their relationship, they are not superimposed. So therefore, this wrist image is indicative of more of a external oblique rather than a lateral projection. So how do we correct this? We need to externally rotate the wrist to achieve that lateral projection. We're going to review this lateral projection of the practice analysis together. We haven't really talked about this much. However, there is a time where the distal forearm and the wrist can be out of alignment with each other. And this is one of those cases. If you take a look at the position of the pisiform and the scaphoid, you can see that the distal scaphoid is shown distal to the pisiform. This is indicative of ulnar deviation. Where the wrist is positioned higher than the elbow. In order to take corrective action, we need to position the wrist neutrally by elevating the proximal forearm to align it with the long axis of the third metacarpal and the mid forearm parallel with the IR. Go ahead and review this practice analysis and answer the following question. So let's break this down together and figure out what's going on in this lateral wrist projection. Looking at this wrist, if you recall, image analysis guidelines state that we want to see the trapezium in this image. And in this case, the first proximal metacarpal is superimposing that trapezium. This is indicative that the thumb was not depressed or parallel with the IR. In order to correct this imaging, we need to depress that thumb, aligning it with the IR to free that trapezium up from superimposition. Go ahead and review this last lateral image projection and answer the following question. So, like always, you want to make sure that we have all the anatomic structures that are required for the imaging, with which we do. However, are we adequately demonstrating the anatomic structures required for the projection? And in this case, we are not. We definitely cannot see the trapezium in profile here. So, what is going on here? Well, we're going to analyze that positioning of the pisiform and the scaphoid and the relationship. And in this case, the anterior pisiform is in front of or anterior to the distal scaphoid. This should be clue you into that the wrist is externally rotated too much. In order to correct this, we need to internally rotate that wrist until the pisiform and the scaphoid are aligned anteriorly. So now let's move on to our last projection, the PA axial ulnar deviation scaphoid projection. Image analysis guidelines state that the scaphotrapezium and scaphotrapezoidal joint spaces should be demonstrated as open. The scaphoid is demonstrated without foreshortening or excessive elongation. The scaphocapitate and scapholunate joint spaces are open, and the radioscaphoid joint space is open. So therefore, there should be a clear visualization of the scaphoid without superimposition of any of the other radial bones surrounding it. Now, the scaphoid waist, proximal scaphoid, and the distal scaphoid may require different angles being placed on it to adequately get the distal portion or the proximal portion of the scaphoid. This may be anywhere from 5 to 10 degrees cephalic or less in the opposite direction, just depending on patient. The long axis of the exposure field should be aligned with the long axis of the scaphoid. The scaphoid is at the center of the exposure field. The carpal bones, radioulnar articulation, and proximal first through fourth metacarpals are all included within the exposure field. Here are those image analysis guidelines. Please review what you should see in the scaphoid waist, proximal scaphoid, and distal scaphoid, which will all appear differently depending on patient anatomy. Like I always say, God likes to make us all different, and so therefore we may have to take more than one projection to adequately visualize these sections, as it may take a different degree of angulation. So let's go ahead and look at some positioning challenges incurred when positioning for the PA axial projection. Let's talk about insufficient wrist obliquity. Now, I know Merrill's doesn't say anything about overliking the wrist in a PA axial projection, but just hear me out and let's see how this insufficient obliquity relates to the scaphocapitate joint space. When you position the patient's humerus parallel to the IR and then flex their elbow into that lateral position, something interesting happens as the wrist moves into ulnar deviation. Typically, the wrist will naturally externally rotate about 25 degrees. This rotation is ideal because it helps open up that scaphocapitate and scapholunate joint, or scapholunate, joint space, giving you a more open joint space there between those bones. But here's the thing, sometimes the wrist doesn't naturally rotate to that 25 degrees. So maybe the patient can't fully ulnar deviate, or the wrist just doesn't rotate enough. So when that happens, you'll need to step in and manually increase the medial wrist rotation to get to that 25 degrees to get those bones free of superimposition of the scaphoid. Now, what happens if the wrist obliquity is insufficient? You'll notice a few key things that will help you identify insufficient obliquity. The scapholunate and the hamate capitate joint spaces might still be open, but the scaphocapitate joint space will be closed. So this is your cue to adjust the wrist rotation just enough in order to find that balance to achieve the right obliquity and get the clearest image possible without over-rotating or under-rotating, and getting that scaphoid free of superimposition. So now let's talk about excessive wrist obliquity and how it affects that scapholunate joint space. When positioning for a PA axial projection, if the wrist is externally rotated just a bit more than necessary, you'll start to see a few key indicators. The scapholunate joint space will be closed. The scaphocapitate joint space might still be open, but the degree of obliquity will look slightly exaggerated. If the wrist is over-rotated even further, the space will also start to close, and you'll notice that the capitate and hamate begin to show some degree of superimposition. So how does excessive wrist obliquity happen? Well, one common reason is the improper positioning, specifically if the humerus and forearm aren't aligned on the same horizontal plane. This misalignment can lead to too much external rotation, throwing off the ideal obliquity and freeing up that scaphoid of superimposition. The only simple solution here is to just double check your patient's positioning, making sure that the humerus and the forearm are properly aligned. If you recall, I spoke on angling for distal and proximal portions of the scaphoid. And so let's just dive into this central ray angulation and how it applies to both distal and proximal scaphoid fractures. For distal scaphoid fractures, to best visualize these fractures, you want to increase the central ray angulation by about 5 to 10 degrees with a maximum of 25 degrees. This adjustment improves the separation of the scaphoid from overlapping structures, making fractures easier to detect. However, you have to be cautious because if you exceed that 25 degrees, the proximal first metacarpal may project onto the distal scaphoid, obscuring the area of interest. So stay within that range to maintain that optimal clarity. Now for proximal scaphoid fractures, it's just the opposite approach. Decreasing the central ray angulation by 5 to 10 degrees enhances the visualization of this region. So if you take a look here at the first projection, you can see that this AP axial projection was taken with a typical 15-degree angle. Some protocols don't require any angle at all. It just depends on the institutional protocol and requirements of the imaging and radiologist driven. But with this projection, it was taken with a 15-degree angle. Look at the visualization of the fracture here. Now, with a decreased angle, with a second projection taken with a 5-degree proximal angle, we can really see that scaphoid fracture proximal portion a lot more clearly. So what is the takeaway here? For distal scaphoid fractures, you want to increase the angle slightly. For proximal, we want to reduce this central ray in order to look at these fractures more clearly. Go ahead and analyze this PA axial practice analysis and answer the following question. So let's analyze this image together. Again, like every other time, you want to assess if you have all your anatomic structures, and in this case we do. But this is a PA axial scaphoid projection, and so are we representing the anatomy of interest is the question here. Here we have a projection where the scaphotrapezium and trapezoidal joint spaces are closed, meaning we're likely dealing with an issue of insufficient wrist positioning. You'll notice that the hand is flexed, which is contributing to closed scaphocapitate and scapholunate joint spaces, making it harder to see those joint relationships clearly. On top of that, the wrist hasn't been adequately ulnar deviated. This lack of ulnar deviation is preventing sufficient external rotation, which is needed to open up that radioscaphoid joint space. In addition, the proximal forearm is positioned lower than the distal forearm, which is throwing off the alignment of the entire wrist. So how do we fix this? Well, first we want to extend the hand fully and place the palm flat against the IR. This will open up those joint spaces that are currently closed due to that flexion. Next, the ulnar we need to ulnar deviate the wrist so that the first metacarpal and radius are aligned. If the patient is unable to achieve full ulnar deviation, you can externally rotate that wrist by up to 25 degrees instead to achieve that same result. Lastly, don't forget to slightly adjust the proximal forearm to be about 2 degrees higher than the distal forearm to correct that alignment. Making these changes will provide you with much more open scaphoid joint space surrounding it. Go ahead and analyze this image and answer the following question. So let's dive down into this image analysis. In this projection, again, you want to ensure that you obtain all the anatomy necessary. I will say this is some tight collimation, so we may need to open up proximally and distally, depending on hospital protocol. However, let's look at the anatomy. In this projection, we're seeing closed scaphotrapezium and scaphotrapezoidal joint spaces again. This suggests that the wrist position is not adequate. The hand is not extended enough, and the palm isn't flat against the IR. This is also causing the scaphocapitate joint to be closed, while the scapholunate joint remains open. This is a sign that the wrist hasn't been rotated enough. Additionally, the radioscaphoid joint is closed, likely due to inadequate wrist rotation, and the proximal forearm is depressed, which is throwing off the alignment of the distal forearm here. So what do we need to do to correct this? Well, at first we need to extend the hand fully, ensuring that the palm is flat against the IR to open up those joint spaces. We may need to rotate the wrist medially to achieve that 25-degree medial oblique position. This will help open up the scaphotrapezium and scaphotrapezoidal joints. And finally, we're going to elevate the proximal forearm slightly higher than the distal forearm to get that proper alignment. Go ahead and review this last practice analysis and complete the last question. So let's review this last practice analysis together. Again, we're looking for all our anatomic structures, which we have the scaphoid here in the projection. Next, we want to determine whether we are adequately demonstrating the anatomy of interest. So let's look at the anatomy. We see that the scaphotrapezoidal and the scaphocapitate and scapholunate joint spaces are all closed. This typically indicates that the wrist is obviously positioned appropriately. We also notice that the capitate and the hamate are superimposed, which is another sign of improper wrist alignment. The hand itself isn't extended enough. The palm isn't flat against the IR, which contributes to these issues. On top of that, the wrist is externally rotated too much, causing some of the joint spaces to be closed and the bones to overlap. So how do we correct this? We need to extend the hand and make sure the palm is flat against the IR. This will help open up those joint spaces. And we want to slightly reduce the external rotation of the wrist. A little less rotation will help to position the wrist just right and give us a more adequate image of the joint spaces surrounding the scaphoid. This concludes our image analysis of the wrist. If there's any questions, please feel free to reach out.